just again, thanks a million to our lovely morning speakers. And we're going to move on now to Dr. Fiona Kiely and Irene Murphy from Marymount University Hospital and Hospice Cork. So just a little bit about Fiona. Fiona Kiely is a consultant in palliative medicine at Marymount University Hospital and Hospice Cork and senior clinical lecturer at University College Cork. She leads interdisciplinary teams in the care of patients with complex palliative care needs in the community, acute hospitals, and a 44-bed specialist palliative care unit located in Marymount Hospital and Hospice. She's also currently studying for her PhD at the Division of Health Research, Lancaster University. Her research focusing on experiences of immunotherapy in advanced cancers. Fiona is dual qualified as a general practitioner and holds diplomas in medicine of the elderly, child health, clinical psychiatry and clinical dermatology, awarded by the Royal College of Physicians Ireland and the Royal College of Surgeons Ireland and Cardiff University. Additional postgraduate scholarships have included a clinical observationship in Harvard Medical School, affiliated Brigham and Women's Hospital, Boston, Massachusetts, as well as clinical experience in Princess Alexandra Hospital, Brisbane, Australia. She currently chairs the research committee in Marymount University Hospital and Hospice, and personal research interests and publications include topics such as early integration of palliative care, information transfer out of hours for community palliative care patients, structured outcome measurement in palliative care, and the use of big data and technology to support the delivery of specialist palliative care. She has designed and currently directs the first national telehealth in palliative medicine fellowship programme in conjunction with the Royal College of Physicians Ireland and the Health Service Executive. Irene Murphy, Fiona's colleague, is here with her today, and Irene is Principal Social Worker and Lead Person for Family Support in Marymount, where she has been working for 23 years. She previously worked in the National Maternity Hospital Dublin and in addiction services in Cork and Dublin. She is a former board member of the European Association for Palliative Care and has contributed to numerous national and international conferences on specialist palliative care. And Fiona and Irene are going to talk to us today about pillars of health and well-being when living with a secondary cancer. Thanks very much.
Thanks very much for the introduction and for having me here today. I think just to add to that resume, I'm the mother of 2 young children. I also look after 2 dogs, a cat with a disability who fell off the cliff at home last night and is currently receiving end-of-life care in the basket at home as I left this morning, and 6 guppies, 6 fish. So the level of responsibility that rests on my shoulders, not to mind this on top of today. So bear with me if I lose attention. And it's lovely to be here today, and I'm really impressed with the surroundings that you have here, and thanks for the invitation. So, I've entitled my part of the presentation as looking under the bonnet of what it is that we do, because I'm sure many of you coming here today and with the theme of today might be thinking about what is Marymount Hospice actually doing, talking about living well. Surely their area is around kind of the latter part of life, end of life and dying. And I thought, well, in order to understand how palliative care might be part of your artillery or part of your toolkit around well-being in advanced cancer situations, including metastatic breast cancer, we might look today, or I might look at just describing what it is that we do, what you might gain from it, and so on and so forth. So you can leave here and maybe have an informed kind of thought process around what it is about us that might help or empower you at particular points in your personal cancer experience going forward. So that's kind of the topics that I'll be dealing with through this presentation. Okay, so just looking at this infographic, and this came from MD Anderson in the United States. And I suppose, what is palliative care about? So if you look at these 2 car journeys, just to start with, so you've got car A and you've got car B. They're both going to take a trip on the exact same road. That road has bumps along the way. It has extreme heat along the way. There's a possibility of oil spills and what that might mean for you. Car B is going to undertake the exact same journey, the exact same road, it's the exact same length, and has the exact same goal. You want to get to work, and you want to get to work on time. But if you look at car A, that has no comfort and no safety features, meaning it doesn't have air conditioning, so the heat, you're going to be sweaty, icky, have a smell of BO off you for the rest of the day when you actually do get there. It doesn't have seat cushions, so you know there's bumps on the road, so you know you're going to be uncomfortable. It's probably going to put your disc out and your back again. You're going to feel that at the end of the journey. And my God, if you hit that oil spill or accident along the way and you don't have your seatbelt on, well, you know, that's going to be bad news for you. So the goal of getting to work or getting to the work on time is probably not going to happen. But if you look at car B, and as I say, same road, same distance, same obstacles and challenges, but you put in some comfort and safety features along the way, so your air conditioning, your seat belts, you're insured to make the journey, you're much more likely to reach your goal. So the same goal that was there for car A. I think you can probably see where I'm going with this. Now, if we apply that same way of thinking to the course of serious illness, specialist palliative care could well be considered agents of safety and comfort, or contributors to this, as we don't have complete ownership of that space. And therefore, we are possibly contributors to well-being along that road that clearly has obstacles and challenges along the way. So we might look at things like comfort in terms of pain and other symptom control, for example, and safety in terms of developing coping strategies, rehabilitation to maintain and improve physical function so that you're able to get to work, look after your children, your other family members, and some advanced health and life planning, so those kind of safety options to give the best opportunity for current and future care to be aligned with your individual values and preferences. So a degree of future-proofing, if you like, giving some space to considering the what-ifs. And while we hope for something, just in case this happened, just supposing that oil spill was there and we careened off without a seatbelt, what is it that I would want to maybe do to prevent that or mitigate the impact of it should it arise? So kind of depending on whether people access or do not access specialist palliative care during the course of these illnesses can significantly impact the experience and outcomes for people. Now, I'm aware the focus for today is on a particular disease state, it's metastatic breast cancer, and this describes a specific pathology affecting your breast and other tissues in your body. Someone has looked at cells under a microscope, someone has scanned you to make that diagnosis. It's a pathological reality. And while particular services, diagnostics, therapeutics may be configured around this disease state, our focus of care to enable living well with metastatic advanced cancers is focused on engaging, however, with your illness. So that's to say it takes heed of your subjective, your completely unique experience of the disease in your individual context, taking account where you've come from, past life, your present life, and what you anticipate your future to be. So that is a personal reality, and that's what we engage with. I mean, 72-year-old Mary Murphy with a HER2-negative breast cancer, who's the main carer for her husband with a dementia, may have the same histological findings as Tina O'Brien, 42-year-old single mother of 3 children under 12, but the health and social issues that will surface for both and how they will engage with their health and their well-being and what that means to them is going to be very different. Same disease, different illness. So you'll be relieved to know that in palliative care, we treat illnesses, not diseases. And the understanding is really well phrased by Dame Cicely Saunders. So she's considered a modern foundress of the modern hospice movement. And her statement really is, you matter because you are you, and you matter all the days of your life. And by that we mean from the point of diagnosis to the point of disease progression and beyond. Okay, so we're there to kind of travel that journey with you. Okay, so now you might be asking, well, what is it actually going to do for me? And we'll talk a little bit about that. So specialist palliative care, and you've lovely photos here of Marymount University Hospital. It's a highly specialised form of medical care, and it focuses on the unique needs of individuals and their families as they cope with the effects of progressive and serious illnesses and the associated treatments. And we work closely with hospital and community-based healthcare colleagues, so we don't operate in isolation. And we're a multi-professional specialist palliative care team, and our focus is on ensuring each patient is as well as possible throughout so they can maintain normal life, family, work activities to the greatest possible extent, and retain dignity and identities throughout, regardless of how unwell you might become. In the New England Dove Journal, more recently, you can see a definition of what we do is that we focus, our sole focus, and our training is on improving quality of life for people who are, and I've brought out the word, living with, not dying from, a serious illness and their families. And if you go down to the end, you'll see it can be initiated at the time of diagnosis and is provided concordantly with all other disease-directed or curative treatments. Standing on the handbag to just get it out, yeah. Take your time. Take your time. And the evidence is compelling at this point. Involving our expertise early in the course of serious and progressive illnesses is hugely beneficial for patients and families and health systems, and is now well proven through many major clinical trials. The impacts you'll see listed there, I mean, who wouldn't want that? Reduced pain and symptom burden, reduced unnecessary healthcare utilisation, improved quality of life, improved family satisfaction and bereavement morbidity. In some instances, improved survival, and I'll talk a bit about the mechanisms behind that, and improved depression, anxiety and post-traumatic stress and distress. Okay. Now, integrated palliative care is considered standard of care by an increasing number of international cancer organisations and features in the treatment, getting the treatment right section of provision of optimal cancer care within our own national cancer strategy, as you'll see there. Okay, so now let's talk about, well, when should this happen and when should this be kind of implemented? So it's an evolving model of palliative care that we're running. Many people still see that top one there, the traditional, the historic and now the old-fashioned approach to palliative care, integration into care, was when all other treatments stopped. So when chemo stopped, immunotherapy stopped, radiotherapy stopped, now you're palliative. So that's now no longer the case. Early palliative care means getting involved early, and you'll see sort of an incremental involvement of our care depending on your situation. And in fact, it tends to be a little bit more wavy than that straight line that's projected there, because we may have more of a role at particular points of complexity and then be able to step back again and maybe discharge you from our service for a period of time when things have hit another area of stability. So like that, okay, that seems to be the more contemporary model that we're now practicing. And so I suppose providing palliative care at an early stage in a patient's illness while using therapies such as chemotherapy and radiation can help better manage symptoms and complications. The key recommendations from ESMO and ASCO also bring out the fact that early palliative care, point of diagnosis and concurrent with treatments is what they are recommending. And this early palliative care piece of work, I mean, we've outlined some of the benefits there in terms of pain and symptom management, but if you look at the hospital system outcomes, they also have a direct impact on your quality of care as well. Fewer unnecessary admissions, lower utilisation of unnecessary investigations. I mean, who wants to be sitting in ED waiting for a scan that isn't going to change your care? Who wants to be in hospital for an extended period of time in a 6-bay unit when that could be avoided and preempted? So they're the types of benefits that involving us as part of the wider healthcare team have been scientifically proven to add. And then our colleagues at MD Anderson went to look at, well, what's the mechanism? If we actually look under the bonnet of this, why does early integration actually affect these things? Because they're big things like improving quality of life and reducing hospitalizations and improving kind of survival rates. Well, if you're integrated early, you have time to look at symptom management. You have time to get in there early in a predictive way. You'll maximise your cancer treatments. So you're likely to prolong your survival because you'll be able to engage with that treatment. You'll have fewer symptom crises. That in itself can impact on survival. It can also reduce your crisis access to the hospital through the ED. the longitudinal support, so for their kind of early and for a little bit more longer time, those kind of things like psychosocial support, anxiety, depression management, and proper spiritual care, they take a little bit of time because you have to build a relationship, you have to build trust, as does the enhanced communication and decision-making piece. So those kind of trickier conversations about those kind of safety measures we talk about, the future-proofing, while we hope for this, what if this happens? But you need to trust your healthcare professional and have a relationship to be able to have those conversations. But they are all directly linked to those really positive, impactful outcomes that contribute to a sense of well-being and living well with your illness. So this kind of graph here comes from the Department of Health in the UK, and it shows a distinctive U-shaped pattern of well-being across the life course in the general population. And you see there from the age of 16 to 54, there's a negative trend of self-reported well-being, with average levels of life satisfaction, worthwhile activities, and happiness levels being lowest and anxiety highest. And it's really disappointing me because I'm celebrating a birthday tomorrow for people aged 45 to 54. So this was very upsetting last night as I put this on the slide. Now, the next sentence was, this may change as we move through life. We have different experiences, responsibilities and circumstances that changes our perspectives. And we see this all the time in the type of work that we actually do. But interestingly, and why I bring it up today, and relevant to today's theme, is the notion that self-reported health is one of the factors most closely related to well-being. So not objective health, okay, so you may have functional decline, you may be spending more time in bed, but if you perceive your health to be good and your well-being, that is linked to well-being. So that's why even as people get progressively sicker clinically, biologically, it doesn't mean that quality of life goes down in that same way. And that's where we come in to kind of find and give space for growing that type of opportunity. And it's notable because the sole focus of the interdisciplinary care that we provide is focused solely on quality of life as perceived by the individual. So that's what we kind of dedicate our work to. And while improving quality of life is a key ambition in the literature, it appears the quality of life of women living with metastatic breast cancer and receiving palliative care needs even more attention. A review was recently enough published. It kind of hoovered up those relevant type of papers that are in the literature out there, and it spat out 4 themes that seem to be coming through the literature that are important considerations here. And number 1, impact of medical treatment on pain relief. 2, the need for psychosocial attention and support. 3, the necessity for an interdisciplinary approach. And 4, ambiguous understandings of the term palliative care. So I was kind of guided by this a little bit in what I've already touched on, and just 1 or 2 quick things that I'll go on to touch on before I hand you over to my colleague Irene. So if you look at pain control, a foundational stone, and good palliative care being an integral part of cancer care, and pain control is a foundation stone for a lot of contributors to quality of life and well-being. It helps people to function day to day, cope with cancer treatments, evidence to suggest it may impart a survival benefit. It improves quality of life, and that's a fundamental endpoint for any medical intervention. And we know that pain can be complex. It can be caused by the cancer itself, caused by complications, but it's also impacted by and begins to impact all aspects of your life, not just physical. So the biological, the psychological, the social, the spiritual, existential, the why me and what's important to me. So you can see why an interdisciplinary approach like we have, touching on all of those domains, needs to be the thing that's mobilised to actually even deal with pain control as such. Symptoms are common, and we know they cluster in groups. And importantly, newer evidence is now supporting better outcomes for patients with advanced cancers for symptom monitoring during cancer care. So now we're really interested in monitoring symptoms, and you need to probably think about reporting these symptoms so they can be managed to improve your outcomes. Pain, shortness of breath, fatigue, some of the common symptoms in advanced breast cancer. And in palliative care, during our assessments, we go into these issues in a lot of depth. We employ both drug and non-drug approaches to managing these, and we plug you into our colleagues, our pain specialists, our radiotherapy specialists. We talk about cases with our oncology colleagues to see from the biologics and chemotherapy perspective what can add to getting those symptoms better controlled for you. And our physiotherapy team in the hospice at the moment are really getting good results from their fatigue and breathlessness management programme, a rehabilitative programme, and they're employing self-mastery techniques and self-management techniques and individualised kind of programmes of health and exercise to manage these troublesome symptoms. So, in terms of who provides palliative care, and how is it delivered? Marymount, we're the Cork Specialist Palliative Care Service, and like every other equivalent of us nationally, we don't have sole ownership of the delivery of a general level of palliative care. Rising numbers of people with advanced cancer, that's not always feasible, nor is it always warranted. But perhaps the key points throughout your trajectory, and then indirectly through advising and supporting the other colleagues. In short, the ultimate answer to who provides palliative care is everyone in healthcare. It's the remit of all clinicians to have at least a basic competency, and there's frameworks to guide training and education needs in that regard. And then us as the team ourselves, just to have an understanding, they're led by consultants like myself. We have the likes of Irene for family support, pastoral care, clinical nurse specialists, physiotherapist, occupational therapists, kind of form the core specialty team who dedicates themselves to improving quality of life for people while reaching out to our oncology colleagues, GPs, community colleagues to bring together a very person-centred care approach for you. And you'll probably have found that health systems are typically designed around diseases and not people, which is to say they're badly designed. So specialist palliative care services, we attempt somewhat in our design to overcome some of these system barriers in the way we deliver the service. We aim to meet the patient where you physically are at. So if you're in your home and you can't leave your home, we'll meet you there. We will meet you in outpatients. We will meet you in the acute hospital setting. We will meet people in nursing homes if that's where their place of residence is. So we can kind of cross all those health and social care boundaries, which is pretty unique. And how we operate is guided by a national model of care, which is an evidence-based model, again endorsed by the HSE and National Clinical Programme for Palliative Care. So what we do isn't just ad hoc. There's a system behind it, there's an evidence base behind it, there's a science behind it to effect those positive changes that I just discussed. And we are now facing a lot of new normals, and I'm sure many in the room are part of that new normal due to the successes of treatments, earlier diagnosis, better generalised health status. Contemporary considerations in advanced cancer care include the fact that people with advanced cancer are living longer. The novel and extended treatment implications add to the complexity, and more people are having this experience. And this new health paradigm is forcing us in palliative care to continue to expand our knowledge base and the ability to provide best-in-world, leading world care through research. And just to kind of reassure you that we are actually doing that, so there's our new normals. These are an example of some of the collaborations that we're currently involved with. These are funded research projects that Marymount University Hospital and Hospice are currently partnering with MD Anderson, Oxford Group in the UK, Princess Margaret in Canada, UCC, Christie, NHS Christie, and we are looking at things from understanding long-term opioid use in people who are living longer with advanced cancers, drug safety issues. We are looking at experiences of immunotherapy and how to harness technologies so that you have better access to our services and that we can use data to enhance more sophisticated care planning and decision making. So that's the service you meet when you engage with specialist palliative care in Marymount. And we're also aware of the monumental opportunity that's there around education. We have to upskill our colleagues so they know when to refer, they know how to manage at a basic level. And so we're involved in developing a master's programme at the moment because the palliative care needs in Ireland are expected to rise by 84% by 2046. So we have a big task ahead of us, but we have an appetite for it. There are barriers to referral. Okay, and we're fully aware of those as well. And as I say, the phenotype of the typical patient coming to us is changing and we're integrating earlier. So we have come now from institutional cares for the incurables and dying, which is how hospice care was viewed historically, right up now to a philosophy of care that's life-affirming, life-enabling, and aims to support people to live as well as possible, as long as possible, and in a place of choice. but there are barriers: culture, confidence, practicalities. Communication is a big issue. This study that you'll see kind of to the left of the screen there, sometimes discussion of palliative care is used as a euphemism for dying. So rather than talking about dying, people will just say palliative care, and so the two are just put in together, whereas actually that's not the way contemporary palliative care actually works. There are unfounded fears around opioids, morphine shortening life expectancies, and a lack of understanding of the contemporary wellbeing goals and practices of palliative care. I am really hoping that this video clip might work, and these are my parting words to you. Any fans of the Dunbelievables? Yeah? Just listen to a short little bit of this.
And I went straight into the little room. You know when you've been kind to into the little room inside the house warming after coming from a Christian after stepping up to the phone after Christmas. I was mad for the bit of crack, so I went straight into the little room, and I was drinking away nicely inside, and I'd more to the sitting crate of Guinness Frank, and a half a bottle of Peggy inside me, and I was kind of leaning in an antidote. You know when you've been kind of leaning in an antidote with 2 crates of Guinness and a half bottle of whiskey inside you, like, when who am I seeing on it riding? Jesus is writing to me, Jack, will your mind just riding? I won't, says I'm fine. Well, you know when you be with 2 crates of Guinness and a half bottle of whiskey inside you, like, will you be more than what enough to hold face down? I won't, says I'm fine. And I didn't pure tick with the drink with the 2 crates of Guinness and a half bottle of whiskey inside me. And an angle of 45 degrees to the floor, you know what I mean? Defying the law of gravity, and I gathered up all the figurines that one implemented this. I launched to myself, Jesus, will your minds are going to bring the whole lot down. I won't, says I'm fine. Well, that's whatever move I made. Everything that was at top of the mantelpiece came straight down onto the floor. And where did I end up? Was inside in the fucking fire. Will you get out? Is she your going to bomb? I won't, says I'm fine. You won't take me to rent again. Will you get out? You're going to bomb today. I won't, says I'm fine. And I get your thing with the big with the 2 crates of Guinness and a half bottle of whiskey inside me. Well, that's whatever move I made. I rolled out of the floor on top of the new carpet. Well, if that shit didn't hit the right top there. Jesus, it's Friday. Didn't that look you want to bomb yourself or you want to bomb down the new house? Will you get out the shit? I won't, says I'm fine. And the court in the dish bumped up my back and I could feel the top of the underpants going, you know what I mean? And I was kind of rolling around trying to keep everything under control. Will you get out? You're going to bump the whole place down. I won't, says I'm fine. Well, there's no other alignment. I get things down. As soon as I stood up, that's the blisters, the big blisters, the blisters. The blisters that came up in my back, they were dead. Fuck it, they were dead size. They were big blisters, I could hear. And Bridie took one look at me and she died over the sofa. Will you get out to see you about to bust? I won't, says I'm fine. And I didn't pure tick with the vent again. Will you get out to see you going to explode? I won't, says I'm fine. Well, there's no wonder in liar. Whatever move I made, every blister that was on top of my back burst and Bridie was there. And she was giving out show. I saw the disgrace of the stage. You have to get in you have to knock it down the figure. You have to go into the fire. You have to put yourself on the cap, but you have to explode now over the living room. And you have to make it a show of me, and you have to make it a show of mommy.
What has that got to do with anything I was talking about? So my message today is, please don't wait until you're falling into the fire, rolling around, burning the carpet in Bridie's house, professing how fine you are before engaging with specialist palliative care at points along your journey. We might just be able to help your living well. And I leave you with this kind of infographic, and the point being palliative care is the umbrella and not the rain. So thank you.